starting with osteoarthritis, it is a degenerative joint disease. There is wear and tear of the joints as one ages. Okay, so it is primary and secondary. So primary occurs in the joint de novo because of old age. So most commonly it occurs at the weight bearing joints such as knee and the hip joint. So knee joint is mostly in Indians, okay, because we employ squatting position and all that frequently, and hip joint mostly in Western population. So most commonly, you also have these joints, and you also have thumb involvement. So trapezio metacarpal joint. So T for trapezio and M for metacarpal joint, and also fingers. The DIP is involved. In secondary osteoarthritis, there is already a primary underlying disease of the joint, and because of that, you will have osteoarthritis. So this can occur at any age. So most commonly at the hip. So predisposing factors. See, first you can have congenital maldevelopment of a joint. Okay, so congenitally you can have some maldevelopment of the joint and irregularity of the joint surface, damaged articular surface, okay, any internal derangement, okay, malalignment, okay, and obesity, which increases pressure on the joints. Causes of secondary osteoarthritis of the hip. Whenever you talk about hip, talk about avascular necrosis. So you can have AVN. Anything in medicine, idiopathic. Okay. So then it could be post trauma. Okay. And then you can have alcohol or postpartum osteonecrosis. So avascular necrosis, postpartum osteonecrosis. Any malformations like congenital dislocation of the hip congenitally, or any improper alignment, so coxavara. Okay. So primary, the pathology is, see, first there is an increase in water content and decrease in proteoglycans. And because of obesity also, when the weight bearing increases, there is something called fibrillation of the cartilage. Once the fibrillation of cartilage occurs, there is abrasion of the cartilage and the bone is exposed. So subchondral bone, it becomes hard, glossy, and this is called hibernation of the bone. Okay, so first fibrillation of the cartilage, then abrasion of the cartilage, exposure of the bone, hibernation of the subchondral bone, it becomes hard and glossy, and then at the margins you will have osteophyte formation. Okay, the bone hypertrophies at the margins. You also have loose flakes of cartilage because of abrasion and fibrillation. So these loose flakes of cartilage, they cause superficial inflammation and thickening of the capsule, which leads to stiffness of the joint. So clinical features, again we talked about which joint is most involved. See, pain is the earliest symptom. Initially it is dull and later it is cramp like when you continue the activity. Okay, dull at the start and cramp like on continuation, and there is coarse crepitus also, and there is inflammation, effusion, and swelling of the joint, itis, right? And then stiffness, initially it is because of muscle spasm, later because of capsular contracture. Then you can have instability of the joint and a feeling of locking of the joint. So on examination, you can see because of pain, on examination you'll have tenderness, you can have crepitus, you can have deformity. Okay, especially the medial compartment of the knee is affected, so you'll have a varus deformity. Again, terminal limitation of the joint movements, irregular enlarged looking joint, and effusion. Okay, hip, you can have flexion, adduction, and external rotation. So if this is the hip joint, so you can have flexion, okay, adduction, and external rotation. Next, on x-ray you can see basically in arthritis you will see narrowing of the joint space and osteophytes peripherally, and subchondral sclerosis. So narrowing of joint space, subchondral sclerosis, or some cysts also you can see, osteophyte formation and deformities. Then you can also do serology, ESR, and serum uric acid levels. So drugs, you can use analgesics to suppress the pain. Okay, you can use chondroprotective drugs like glucosamine or chondroitin sulfate. Okay, they damage the repaired cartilage. You can give viscosupplementation, so sodium hyaluronate. So it is injected 3 to 5 times at a weekly interval. And supportive therapy, again weight reduction, avoidance of stress, local heat exercises. So surgery, you can do many procedures like arthroscopic procedures. You remove the loose bodies, okay, meniscal tears, etc. So arthroscopic chondroplasty, for example, you remove the degenerated, fibrillated, abraded cartilage. Okay, and you can also go for joint detachment. Okay, so you open the affected joint, smoothen it out, and excise the excess. And then you can also go for osteotomy, like a high tibial osteotomy or an intertrochanteric osteotomy. Next, you can also go for joint replacement, so most commonly hip and knee, so it serves for 10 to 15 years. Then moving on to cervical spondylosis, it is a degenerative condition of the cervical spine found almost universally in patients over 50 years of age. So it occurs early in persons pursuing white collar jobs. So they're susceptible to neck strain because they constantly keep the neck in one position while reading, writing, etc. So pathology, it begins in the intervertebral discs. Degeneration of the discs results in reduction of disc space and peripheral osteophyte formation. The osteophytes impinging on the nerve roots, they give rise to radicular pain in the upper limb. So basically, in any osteoarthritis or degeneration, so cervical spondylosis and all that, there is narrowing of the joint space, okay, and peripheral osteophytes formation, okay. So in spondylosis, they impinge on the nerve roots, so they give rise to pain. So here it gives rise to radicular pain in the upper limb. So our cervical spondylosis is most commonly found in the lowest three cervical intervertebral joints, so C5 to C6. So clinical features, you'll have pain. Again, you'll have stiffness because you're keeping it in one position only. Yeah, okay, you'll get used to that. And radiating pain along the C6 nerve root and giddiness as well. So on examination, there is loss of normal cervical lordosis. Okay, as you can see here, there is loss of normal cervical lordosis because there is stiffness of the neck and limitation in neck movements. So tenderness in the muscles of paravertebral region. So myalgia is seen. Okay, and lower limbs must be examined for signs of early cord compression. So for example, positive Babinski reflex. Radiological examination. So X-ray cervical spine AP lateral view is sufficient. So there is narrowing of intervertebral disc spaces, osteophytes at the vertebral margins anteriorly and posteriorly, and narrowing of intervertebral foramen in cases presenting with radicular symptoms. Okay. So treatment. It undergoes spontaneous remissions and exacerbations. During remission, you have to give proper neck posture and neck muscle exercises as well. During an episode of acute exacerbation, you have to give analgesics, hot fomentation, cervical collar, and traction to the neck if there is stiffness, okay, and antiemetics if there is giddiness. See, try to avoid the stiffness, avoid the constant same posture of the neck by giving a collar, and traction to the neck if the stiffness develops, okay, antiemetics if there is giddiness. In an exceptional case where spinal cord is compressed by osteophytes, you may have to go for surgical decompression. Then lumbar spondylosis. So this is a degenerative disorder of the lumbar spine characterized by insidious onset of pain, stiffness, and radiologically by soft tissue formation. So cause, bad posture, chronic back strain, it is a commonest cause. Other causes are previous injury to the spine, previous disease of the spine, birth defects, and old intervertebral disc prolapse. So primarily degeneration begins in the intervertebral joint, so you'll have reduction in disc space, marginal osteophyte formation, and degeneration changes in posterior facet joints. So clinically, you will have low backache, okay, pain. There may be a feeling of a catch while getting up from sitting position, which improves as one walks a few steps. Then you can also have sciatica. Pain may radiate down the limb up to the calf, okay, and because of irritation of one of the nerve roots. So paresthesia again on the lateral side of the leg or foot because of L5S1 nerve roots. So as usual, you'll have pain. You'll have a catch because of the stiffness, okay. You'll have sciatica, okay, and also paresthesias. So examination, the spinal movements are limited terminally, but there is little muscle spasm. So the straight leg raising test SLRT may be positive if nerve root compression is present. So following signs are present. You can have reduction of disc space, osteophyte formation, narrowing of the joint space, and again subluxation of one vertebra over the other. So treatment, acute stage, again bed rest, hot fomentation, analgesics, they're advised. As symptoms subside, spinal exercises are advised. In some resistant cases, a lumbar corset may have to be used at all times. Spinal fusion may occasionally be necessary.